Hi everyone, welcome to this Facebook Live event all about ankylosing spondylitis, an inflammatory arthritis of the spine. As we know, AS is not well known and is often considered an invisible type of arthritis. I'm sure many of you out there watching can attest to that you've likely never heard about ankylosing spondylitis until you received a diagnosis or somebody close to you did. So I'm really happy to be able to take this opportunity with Dr. Inman and Jeff to learn more about AS. Just for fun, anybody out there watching live, please feel free to type in the comment section what province that you live in, just to give us a bit of an idea where everybody's coming from. I'm going to start off introductions. My name is Wendy Gerhardt, and I'm honored to be the executive director of the Canadian Spondylitis Association. The CSA is a patient organization with the mission to be the leading voice for the spondyloarthritis community in Canada. We do this by providing support, education, awareness, and advocacy, not only to patients, but to loved ones and healthcare professionals. If you want to learn a little bit more about us, I encourage you to visit our website, where we have our mission, vision, and areas of focus clearly outlined on our strategic plan. So I want to thank everybody for joining us today, and let's dive right into a few questions. We put a few questions together to get us started, and then we encourage everybody watching to post your questions in the comments feed, and we'll try to get through as many of them as we can in the next 15 to 20 minutes. And just as a reminder, we're sharing general health information here today. If you have any specific diagnostic or treatment questions about your personal situation, we recommend that you keep those and speak directly with your own healthcare professional. And so with that, I'm going to start off the questions. We'll start with Dr. Inman. So Dr. Inman, can you start by explaining what ankylosing spondylitis is?
Right. So thank you very much, Wendy. So my name is Rob Inman. I'm a rheumatologist based at Toronto Western Hospital, and where I'm the director of the spondylitis program with Dr. Nigel Haroon. So to answer your question, Wendy, so ankylosing spondylitis is an inflammatory type of arthritis, which affects predominantly the spine. So it can affect other joints, hands, hips, shoulders, knees. It can affect other organs like inflammation in the eye, the gastrointestinal tract, of the skin. But the primary burden of the disease is inflammation in the spine, particularly in the low back, which is accompanied by pain and stiffness and fatigue. And I would say from the patient's point of view, pain, stiffness, or fatigue are the dominant symptoms. When we say inflammation, we mean that there's an immune reaction against some tissues. So we sort of think of this as like an autoimmune disease. This isn't to distinguish it from a more common cause of back pain, which we call mechanical back pain, which is important in the differential diagnosis. So we know a lot about AS, but there's still some mysteries that are yet to be uncovered. Most specifically, what's the primary cause of the disease is not known.
Thank you. And I'll turn it over to Jeff to do an introduction about himself and a little bit of personal story.
Thank you, Wendy. My name is Jeff, and I have ankylosing spondylitis. I will be 58 years old in about 2 weeks' time. I felt my first symptoms in my mid-20s, so I have over 30 years of experience in dealing with the pain and fatigue and stiffness to some degree, almost every day for the bulk of those 30 years. I have, however, for the most part, led a very normal life. I had a long career in sales and sales management, mostly in the computer industry. Although I did take an early retirement here in my 50s, and I have done a couple of different things. I have taken on a sort of a part-time manual labor job, which I am just enjoying the heck out of. It's really been great for my mental and physical well-being. And also I've done a fair amount of volunteer work trying to help people in my situation who are maybe just starting off or who are much younger. So I've been working with the CSA for about 5 years, and have enjoyed that thoroughly, and would encourage anyone on the call who isn't a member of the CSA to become one. It's just a fantastic resource for patients like myself. I have a wife, a very actually supportive and loving wife, and that's one thing that you need with this disease is a support system, a good family support system. It can make a massive difference in your health outcome. I also have a live-in therapist, which is rare. Now, this therapist does physical therapy, goes for walks with me every day, also does a lot of mental and emotional support as well. And I'm in my wife's office, and I did notice that she had a picture of him. And he's an 11-year-old beagle, and his name is Dexter. And again, I would highly recommend anyone suffering from a chronic pain disease to have a pet. They can be your best friend in times when you're feeling a little bit down. So thanks, Wendy.
Excellent. Thanks for sharing, Jeff. And everybody needs a little pet to help them out. Dr. Inman, getting back to a little bit more about AS, can you tell us more about the signs and symptoms and why it's often difficult to diagnose?
Right. Good question, Wendy. So this is a real issue that troubles both rheumatologists and patients, because there's a significant delay between the onset of symptoms and the diagnosis typically. And often this can run for an interval of 5 or 6 years, where patients will be struggling with low back pain and they won't get appropriate diagnosis or appropriate referrals. And then finally, somebody puts it together. So with a referral to a rheumatologist. Why is that? Well, I think, as I mentioned before, the mechanical back pain, which is the low back pain, osteoarthritis of the spine, mechanical strain, disc problems, actually constitute the major cause of most back pain in individuals, right? So spondylitis, if you take all the Canadians with low chronic back pain, it'll be a fairly small percentage that actually might have AS. A lot will have mechanical strain on the basis of disc disease or osteoarthritis. So part of the problem is the frontline first contact with the healthcare system. It might be a family doctor, it might be a physiotherapist, it might be a chiropractor, massage therapist. But so patient, where if the course of the disease is confined to the low back, it might be managed by these alternative approaches to management, treatment, without a referral to a rheumatologist. So that has always been a challenge for the field about how we can actually get patients to an appropriate healthcare professional more efficiently, more quickly. And again, what confounds the problem is there's so many people with non-specific low back pain that a GP, for example, can't really screen every patient with back pain that comes in with AS. So there've got to be sort of clues. And we're working on this now, Wendy, with how we can actually triage patients more effectively. We're using a team of physiotherapists in the province of Ontario that have advanced practice training. And if they can actually triage and say, well, this is more likely to be AS than mechanical back pain, that would facilitate the problem. But it is a source of frustration for many of our patients that they've gone through a whole bunch of variety of different healthcare providers and a lot of alternative complementary medicines, for example, before somebody says, well, you probably should see a rheumatologist and get to the bottom of this. So it's an ongoing challenge for us.
Yeah, and just to comment on that, and it's not just in Canada that there's a delay in diagnosis. It's really it's a global issue, and I know that we're doing some work with ASIF, which is a global organization to kind of try to look at what we can do to try and reduce that time globally.
Okay.
My next question is to you, Dr. Inman, again. What are extraarticular manifestations? What are they, and why should people be aware of them?
Yeah, so that's a great question. So extraarticular manifestations means something beyond the joints, right? Articular means joints. So what are the features of ankylosing spondylitis that occur besides the joint pain and stiffness of the spine. So there are really three primarily. One is inflammation in the eyes, that's called uveitis or iritis, and that occurs in about 35% of our AS population. It's usually manifest by pain in the eye, usually one eye at a time, sometimes sensitivity to light. And it's important for an ophthalmologist to assess that rather urgently because it's treated very effectively with local steroid drops. So that's the uveitis piece. The second piece is inflammatory bowel disease. That occurs in about 12% of our patients. So this could be Crohn's disease or ulcerative colitis. And we often co-manage those with the rheumatologist and the gastroenterologist. Just as an aside, there's a lot of research that links inflammation in the GI tract to inflammation in the joints. That's a very hot area of research at the moment about why they should be related. And then the third area is skin and manifest, and that's psoriasis. So about 10 to 11% of our patients have psoriasis. So for example, one practical consequence of that, Wendy, is that when we're talking to GPs or family practice residents or physiotherapists, if they see a young person with back pain, they should at least have a question about, do you have any trouble with your eyes or your GI tract or any skin rash? Because that can often be the clue that something really is going on besides just mechanical back pain.
And everything that you've said is so in line with what we learned on our quality of life survey. It's very closely linked, and many people do have additional complications
Yes.
to their condition.
Right.
So Jeff, you talked a little bit about volunteering with the CSA and running support groups and getting involved with younger people. What kind of advice would you give to somebody who's recently diagnosed with ankylosing spondylitis?
Yeah, that's a really great one. I have learned most of these lessons the hard way. My first piece of advice is always find a good rheumatologist, someone who has some knowledge and experience of ankylosing spondylitis. Not all rheumatologists are created equal, and they can make a massive difference in your treatment and your health outcome. In addition to that, finding a support group if possible, or at the very least, finding a way to connect with other people who have the shared experience of ankylosing spondylitis was incredibly helpful to me. It's nice to have that support, but it's also important to talk to other people about non-pharmaceutical therapies that are out there and available, because there's boatloads of things that will work for some people, not necessarily for all, but we kind of share back and forth things that are working, and you can try new things and find ways of getting some relief from the pain and stiffness that are non-pharmaceutical. Additionally, your mental health plays a massive role in your pain and how bad your symptoms are. So you really need to spend time working on your mental health. So, for me, things like meditation, yoga, mindfulness-based stress relief have made a massive difference in my outlook on life in general and living with the disease. Looking at things on a daily basis rather than long-term. I think about my disease as the weather. So it could be bad today, but it might be great tomorrow. The weather generally lasts 3 to 5 days in one type of system, and you're out the other end. So never get too high or too low, depending on how things go. And it really helps your mental health as well. And lastly, I mentioned non-pharmaceutical therapies. It's absolutely critical for those of us who, have a lot of pain and severe symptoms to look at those things to go on top. But certainly the base and the most important thing is the pharmaceutical part of it. But in addition to that, if you really want to be able to be active and lead a normal life, you have to start looking at all kinds of exercise programs, look at different therapies like acupuncture, fascial stretch, massage, even things that are simple like warm baths or cold packs on your body have their place and can be helpful. Diet was another big one, a big impact for me, which sounds awful to people, but believe me, if it takes away some of your pain and fatigue, you would get rid of different foods in a heartbeat. So that's pretty much it.
Great, thank you.
Mhm.
All of those insights are really important, and you know, not everybody's different, and so what works for one person might not work for another. So thanks for offering up what some advice that you would give. You know, fortunately for people living with AS, there are a lot of community resources available. I encourage you to visit the Canadian Spondylitis website. We're regularly adding fresh content based on feedback from the community. And in addition, you know, we offer a lot of events. In the past, we've offered in-person events. That's obviously on hold for now, but we're doing a lot. We're making up a lot of traction in offering webinars, and we have a few planned over the course of the next 8 to 10 weeks. We have one coming on biologics, sort of helping people to understand more about that class of medications. We have a webinar coming on psoriatic arthritis. And lastly, in the beginning of November, we have one on managing pain in chronic inflammatory conditions. So I encourage everybody to visit our website because we continue to add new programs and new content, as I mentioned. So we are getting some questions coming in from individuals who are watching. The first one is from Karen, and her question is diagnosis of AS primarily an exclusion of other diseases? I imagine that's one you want to handle, Dr. Inman.
No, so that's an important issue. So the diagnosis of AS is sort of a constellation of several clinical features. If you generally, amongst rheumatologists, the gold standard is actually the X-ray. So the X-ray, but not of the lumbar spine, it's actually of the pelvis. So probably the central test that most anchors the diagnosis is usually what we call an AP pelvis X-ray, where the sacroiliac joints can be visualized, because that's the first and predominantly targeted joint in this disease. Now, there are very other important adjunctive things, but in addition. So for example, the sedimentation rate, the CRP. So if a patient is seen by a GP and with back pain, he might just screen with inflammatory markers in the blood, simple blood test, just to see whether anything is going on. Because typically those inflammatory markers would be normal in mechanical back pain, but elevated in AS. So that's clue number one. The B27 test is an interesting question because it's present in about 90% of patients with AS. It's a simple blood test of a gene, but its specificity is not that great. What we mean by that is if probably 90% of patients, more than 90% of patients with the gene don't have AS. So the interpretation of the test is important. We do include it in the diagnostic workup, but just having a B27 positive test doesn't make the diagnosis. In fact, we see a number of patients referred to our clinic who clearly have a disc problem, and they incidentally were found to be B27 positive, but the cause of the back pain is actually the disc, not AS. So I would say the blood tests are fairly simple, inflammatory markers, the B27. The X-ray is the kind of the gold standard. Now, in the recent years, MRIs become very important in this discussion too, because we recognize now that there are patients that can have inflammatory back pain but have normal X-rays. The X-rays actually show whether there's any damage in the sacroiliac joints. The MRI tells us whether there's ongoing inflammation. So we recognize now that particularly in the early course of the disease, there may not be any X-ray changes at all. But if we have an index of suspicion, so the pain sounds inflammatory, they have morning stiffness, they're waking up at night, the back pain seems to get better when they exercise, not when they rest. If there are clinical clues like that, plus the blood tests I mentioned, and if the X-ray is negative, we will often go on to an MRI just to find out. And we get this very bulky term called non-radiographic axial spondyloarthritis. It's just it's a terrible term. It's too complicated. If we had it to do over, we'd rename it. But I mentioned that by what we mean as non-radiographic is the X-ray may be negative, but you can still have AS. So generally, when we get to the imaging, we have X-ray positive changes, which we call classical ankylosing spondylitis. And we might have MRI positive changes, which we call this bulky non-radiographic form. It's important though to recognize that, because that's another cause for delay in diagnosis. Like the patient, the x-ray might have been done by a GP or say an orthopedic surgeon or anyone else. And if the x-ray is normal, they might be told, well, you can't have AS. But in fact, the MRI can be very, very helpful there to uncover some ongoing inflammation. Interesting, just in passing, that non-radiographic form, the x-ray negative form, tends to be more predominant in women than in men. So that's another thing that confounds the delay. The delay in diagnosis is even more pronounced in women than it is in men, because it's thought to be sort of a male-dominated disease. So a lot of clinicians don't think about it. But we do think that gender plays in a very important role on how the disease is actually expressed. But the MRI positive patients tend to be more women than they are men.
Wow. That really speaks to just how difficult it is to diagnose.
Right. It's not really a simple blood test. And we rely, as Jeff said, we try to, one of the reasons the forums like this, Wendy, are so valuable, and we do them with our rheumatology colleagues, but it's also the frontline clinicians, again, the physiotherapists, sports clinics, massage therapists, chiropractors. Many healthcare professionals see patients with back pain.
Yeah.
And they don't all have to be seen by a rheumatologist, but we feel it's very important that in terms of our community education, professional education, that there's at least an index of suspicion, that everybody's at least got their antennae up, that this back pain in this young person could actually represent AS.
Right, right. And there's an opportunity for awareness on our part to the broader public about the differences between mechanical and inflammatory back pain. So it kind of speaks both ways, right?
Right.
I'm going to jump to another question. Sorry, this is from Raphael. Is it good to keep a really active life despite any pain? Is it good to just keep doing it, or could it be dangerous? So I'll let you start, Dr. Inman, and then I'll let Jeff add on.
Yeah, well, Jeff can speak to that. So from our point of view, exercise is a really good thing. I mean, it's kind of the cornerstone, Jeff alluded to, non-pharmacological treatment. So you look at the treatment algorithms from the Canadian or American or European organizations, they're anchored in education, pain and support groups like we're talking about now, but physical therapy and exercise is really critical. We don't believe, Raphael, that exercise does any damage. And we do caution patients, for example, certain loading of the back, like deadlifts, weights in the gym, high impact sports sometimes, like hockey or professional, rugby. We caution people with high impact sports, but apart from that, whether it's biking, swimming, running, we really encourage our patients to get back to as active a lifestyle and an exercise program as they can manage. Jeff?
Yeah, I agree 100% that one of the most important things is staying active, and as active as you possibly can. For me, it has been about breaking it up into multiple units throughout the day. It's very difficult for me to have the stamina to do long periods of time of exercise, but if I break them up into 20 or 30-minute segments and do them 5 times a day, they really have a good cumulative effect in keeping my symptoms, most particularly my stiffness and pain, down. So while I'm doing them, I'm not feeling any particular relief. The relief always comes later. So I also know that if I went to a movie and sat in a movie theater for 2 hours, I wouldn't necessarily feel pain in that 2 hours, but I sure would an hour later after getting out of that theater, and probably for the rest of the day. So there's no question in my mind that staying active every single day is important.
Cool, thanks. There's been a couple questions about diet. So maybe Jeff, you can talk a little bit about that, and we'll let Dr. Inman weigh in from his perspective.
Yes, and this is one that really varies from person to person. We found in our support group that diet to some extent does impact everyone in our group, but it's also very different foods that impact people. So for me personally, I went to a nutritionist, and had it very personalized for me. But we've had a lot of people who've had success with a couple of very common diets, and that is the paleo diet, and that has worked well for some AS sufferers, and also people have gone completely into the AIP, the autoimmune protocol, which was a little harsher than I could deal with or wanted to deal with, and I had good results in other areas. For me, removing gluten and dairy were the two big ones. They made a massive difference in the amount of inflammation that my body produces in any given day. And yeah, the diet has been very impactful to me and to most people with AS that I've talked to.
Yeah, I would just to back up and agree with Jeff. It's really quite individualized. So we encourage people to research around, make sure they're getting appropriate nutrition, and ideally talk to a nutritionist. But sometimes it's often trial and error. So the common eliminations we hear, as Jeff said, lactose and gluten reduction, processed sugars. We have a number of patients that really go to a low carb diet. There was a little bit of rationale for that when there's a theory around Klebsiella in the gut. You might have seen this popularized for a while in the AS literature. We don't think there's a lot of strong argument now for Klebsiella, but anecdotally, we've seen patients when they go to a low carb diet, they just seem to be doing better. Now, often other things are taking place. They're often losing weight, right? So if they've lost 5 or 10 kilos with the new diet,
Yeah.
all of a sudden the mechanics of the low back are getting better. So we celebrate that. I mean, if it's whether it's a direct effect of dietary change or an indirect, if it improves the symptomatic control, it's all good.
Yeah, perfect. And I think you hit it bang on, as it's different for everybody, but it's really important that we're treating it. If you are at the point of needing pharmacologic intervention, that you're on the right medication, you're getting in that activity, and you are playing around with the different kind of foods out there, because everybody's different. And I think it just takes people time to kind of work through things to figure out what works for them. Just on the point of nutrition, I did want to add that we ran a webinar in March, and it's hosted on our website. It was given by 2 registered dietitians. So if anybody's interested, it's archived in the videos on our website. Let's see, the next question. There's a question about, is there genetic testing for AS?
Well, the B27 test, as I mentioned, on a first pass, you might say it looks pretty good. It's a test that's positive in 90% of AS patients. The problem is, the downside, as I said, is most patients with the B27 don't have AS. So that's where it gets complicated. So that's the closest we've come to a test. Now, there are actually about 100 other genes besides B27 that contribute to risk of AS. But they're relatively minor. So some recent studies from Australia and the UK, if you add some of these additional genes, you don't gain much more than you learned with B27 alone. So we think it is genetically determined in terms of risk. So just one point on genetics. There's some genetic disease like sickle cell anemia. If you're tested for the sickle gene and you've got that, then you've got the disease. That's a direct gene disease relationship. AS, like most autoimmune diseases, doesn't really work that way. What the genes do is they adjust your susceptibility. That's all. If you inherit a particular gene, you're more likely to develop a particular disease. This applies to rheumatoid arthritis, lupus, right across the board. But it doesn't make the diagnosis. But it does, for the clinician, often heightens his level of suspicion. So if somebody's coming in with back pain and they've got a history of iritis and they're B27 positive, already the clinician has sort of got his antennae up. He's more alert to the possibility of AS.
Thank you. We have a question here from Vera on the general types of treatments available for AS. Can you comment on that, Dr. Inman?
Sure. So basically, we stage this. If you imagine a sort of a pyramid, so the base of the pyramid would be exactly what we're talking with Jeff. So patient support groups, patient education, physiotherapy, exercise. That's the kind of the ground. That's where we always start. And in fact, are probably some AS patients that do perfectly well with that don't even never see a rheumatologist. We don't really know, but that's likely the case. Then we move to pharmacological treatment, and that's the non-steroidal anti-inflammatory drugs. That would be ibuprofen, diclofenac, Indocin, Celebrex, etc. And by the way, there doesn't seem to be a big difference between those, between Advil and naproxen. We tend to treat them pretty much the same in terms of effectiveness. Sometimes their side effect profile changes a little. So you'd have patients that are responding to the physiotherapy and exercise. Then you've got the NSAID group. So and often they're doing well too. In our clinic, we have 20 or 30% of our patients that just are doing fine with the exercise NSAID combination. The big change in the last 20 years has been the biologics. So that's for patients whose symptoms are not well controlled with exercise or non-steroidal anti-inflammatory drugs. We now have a different option. And that really did change the treatment landscape of AS in about 2000, 1999, 2000. And so these are the first class of drugs are what we call TNF inhibitors. So that would be infliximab, golimumab, etanercept, et cetera, certolizumab. They're very effective for treatment, not 100%, but I would say in general, 70, 75% their treatment, and they improve symptoms. There's also evidence they actually can improve long-term outcomes. So not just symptomatic control, but possibly disease progression. And then in the last 2 years, a second class of drugs, what are called IL-17 inhibitors, has come on the market. They look in general comparable in effectiveness to the TNF inhibitors. So they're actually about 5 TNF inhibitors and 2 IL-17 inhibitors on the market in Canada, approved for AS. Potential side effects, they're costly. So it's either usually a private insurance coverage or the Ontario Drug Benefit Plan in Ontario or the Provincial Health Benefit Plan. They're given all by injection. So they're either given intravenously in the case of infliximab or by a subcutaneous injection in the case of golimumab and secukinumab, et cetera. Safety profile has generally been very good. We're very encouraged by that, both the risk of, say, unusual infections and cancer, very good. But of course, you talk that over with your rheumatologist at that time. And the long-term effectiveness over time seems to be well tolerated. So that's the relative strategy. The base is non-pharmacological, then the non-steroidals, and then the biologics.
Perfect. And I just wanted to add in that we are holding a webinar in a couple of weeks on biologics and biosimilars. Encourage everybody to that's looking for more information and to understand that class of drugs to join us for that one. And in the plans for later this fall or very early in January is to hold an actual webinar on all of the treatment options, because I think it is a bit of a confusion point for a lot of patients, and they don't understand sort of the pathways that you have to go through and that kind of thing. So that is also coming up in the new year as well. One more question. Can anyone get referred to the Toronto Western AS Clinic?
Sure. I mean, just have your GP just fax in a referral. Oh, yeah, that's fine.
Okay, perfect. You might get a swarm of faxes now, Dr. Inman.
We'll put them on the Mudge diet when they come. Yeah. Just don't kick me out because of it.
And I just have one more question. No, I actually have one more question that was brought up to me a lot very quickly, and I know we're kind of going over time, is do you have any comments, Dr. Inman, about AS and women? I know you talked a little bit about that, you know, historically it was more commonly known as a male disease, and it generally takes women longer to get diagnosed. Any advice out there to women? Because it's something I commonly hear that women are being told, you know, for years that it's a man's disease and they can't get it. Can you comment on that? Well,
I mean, again, we sort of see that as our responsibility, Wendy, and working closely with the CSA is making sure we get this message out there. It affects men and women, very importantly. So we need to make sure we're communicating with the frontline workers, GPs, physios, chiropractors, et cetera. I would say besides the delay in diagnosis, if you look at, so it's an interesting dynamic. So generally, if you compare AS men and women, X-ray changes are more advanced in men than women, but the pain scores are actually higher in women than men. So we also see inflammatory markers like the sedimentation rate and CRP tend to be higher in men than women. So there's a lot of biology behind this. We've looked at, for example, some of the T cell profiles in the blood of patients, and they're really quite different between males and females with AS. So there's something very biologically important. I think the other issue that comes up commonly in our discussion in this context, Wendy, is pregnancy. So we have a number of women with AS will be very concerned about pregnancy safety, exacerbating the disease. So we've done some studies on that, and happily the bottom line there is we don't think that pregnancy necessarily worsens or accelerates the course of AS, and we have many AS women that have had successful pregnancies, so that's good news too.
Perfect, thank you. I'm gonna wrap up, everybody. We've gone over the typical time for a Facebook Live event. A big thank you to you, Dr. Inman, from the Toronto Western Hospital, and thanks to Jeff for being very open and sharing your perspective and your experience. I know it's always nice to hear from people who live with, and it's very motivating and encouraging. I also want to thank AbbVie for supporting this Facebook Live event, and a big thanks to everybody out there who's watching. I think we've had well over 250 people. So big thanks for you guys for being engaged and asking questions. And if you have any feedback on this broadcast, please feel free to put it in the comment section. As we mentioned before, this video will be archived on the CSA Facebook page and also on our YouTube channel. So feel free to share the link with others who might benefit from watching it, and that should be available probably later this week, if not even this evening. And I wish everybody a great rest of your day, and thanks again for being involved.
Thank you, Wendy.
Thanks very much.